So we'll use this to have a look at some of the case studies associated with imaging. So first one we'll have a look at is an injury 16 years ago, bilateral leg numbness, ataxic, difficulty with micturition, altered sensation left buttock, positive Hoffman's. We're querying demyelination, myelopathy, stenosis. These are the images. So looking at the spinal cord itself, looking at the disc bulges shown here and here. And then looking at the section, you can see here spinal cord preserved, and then here you can see the significant narrowing of the central canal here. So the report showed significant narrowing of the central canal at C5, C6, secondary to degenerative disc osteophyte complex. So at this point, would we have been recommending surgery? So this patient went on to have surgery. So you can see around here where the surgery, so you can see the lesion, and you can see that the disc bulges are no longer there. Looking at the transverse section, so you can see where previously there was impingement and this wasn't clear, you can see that it's much clearer. So you can see from the report here, post-operative changes are noted at C5, C6 on comparison with the previous MRI. You can see the resolution of the cord compression, but some higher signal based on the surgery. So, second case study. Lower back pain radiating down the left leg with numbness of the left big toe. Positive sciatic stretch, so we're thinking potentially disc, nerve root irritation. Looking at the image. Looking here, disc bulge. See abnormality, abnormality here. Moving on to the transverse section, looking here onto the left-hand side here. So the report showing large left paracentral disc protrusion and then some mild to moderate disc bulging, but no significant neural compression. Case study 3. Worsening neurology, known L4, L5 disc prolapse with impingement, but now presenting with new onset saddle paresthesia, worsening bilateral pins and needles, and concerns regarding prolapse and potential cord requiring. So looking at the images, you can see the spinal cord running down here. You can see minor disc bulges, but nothing that's compromising that central canal significantly enough to get to the spinal cord. Looking at the transverse sections, you can see there's a little bit of a disc bulge here, but again, it's not affecting the spinal cord itself. Report shows previously noted left paramedian disc extrusion, markedly smaller when compared to the previous study, and not causing neural impingement, so no central neural compression or issues with exit foramen compromise, so just some moderate left-sided facet joint degeneration. Next case study. So we've got somebody who has a long-standing weakness in their left hand, C7 to T1, decreased sensation predominantly along C8, reduced triceps jerk on the left and the right, previous history of breast cancer and left mastectomy in 1990, positive Hoffman's on the right but no pain, tendency to increase reflexes in the right upper limb and left lower limb. So you can see general degenerative changes throughout the spine itself, and you can see dehydration of the discs. Over down towards here, you can see some lipping, some osteophytic lipping, but again, nothing's compromising the spinal cord itself here. Looking again transversely, spinal cord itself sits absolutely fine, but nothing's compressing any of the nerve roots or any of the spinal cord. So report normal craniocervical junction. There's no intrinsic cord abnormality. Some cervical spondylosis noted, and then some small end plate osteophytic ridges. Okay, so previous right iliopsoas tenotomy and now has a new onset right hip pain. We're looking at these images here, looking at the hips themselves. They look quite nice. But if we look higher up at the psoas and iliacus, you can see on the right-hand side, you've got significant atrophy in comparison to this side here. Then looking over at this one, this sequence, you can see this high signal white here. Okay, not sitting with anything that we deal with as MSK practitioners. But if we move forwards, looking at the hip and labrum again, so nice and rounded, labrum looks normal. Moving forward, significant right iliacus and psoas muscle atrophy in keeping with previous tenotomy. There is, however, 48mm right ovarian cyst, and this may be contributing to your patient's symptoms, so therefore we'd refer on to gynecology. So again, we're not looking, this here is not something that we would deal with, but in incidental looking at the hips themselves, we've found that there's an issue here. Case study. So, looking at history of Ehlers-Danlos syndrome, Baton score 8 out of 9. So looking at the knee itself, so this is a skyline view. So no trochlear dysplasia, so the trochlea itself isn't flattened, and the epiphyseal plate looks normal. However, you can see here you've got this high signal, which would indicate some swelling or some fluid around the knee itself. Moving forwards, you can see that there is some laxity of the medial patellofemoral ligament because it's sitting slightly further over laterally, but nothing there of any significance. There's nothing there where we're indicating any trochlear dysplasia, nothing where the patella itself is sitting dislocated. There's no joint effusion, there's no chondral defect. We're not looking at any bits that have broken off, no loose bodies sat within this MRI scan. And the ultimate report said that there was no issues with trochlear dysplasia, the ACL, PCL, MCL and ACL are intact, and there was no bony contusion. So if we just go forwards, so you can see trochlear dysplasia, you can measure it on looking at the MRI scans, looking at the perpendicular lines. So thinking about the trochlear shape, so your A line sits posterior to your knee joint itself. Your B line then sits perpendicular down through your lateral condyle. Your C line sits down through your medial condyle, and your D line sits straight through the dip and the deepest portion of the trochlea. So what you do is you take your B line, add it to your C line and divide it by 2, and then you take away your D line. So what you're looking for there, trochlear dysplasia would be a figure or a normative value where your difference, your trochlear depth, is less than 11mm. But most people eyeball it because you can see really quite nicely here trochlear dysplasia, whereas this one you can see the deep nature of the trochlea. Moving on to incel salvati, the ratio of patella tendon length to patella to determine the patella alta or bargia. Knee should be 30 degrees flexed, and 0.8 to 1.2 is considered normal in terms of a difference. So you're measuring the length of the patella and the length of the patella tendon, and the difference between these two values should be between 0.8 to 1.2. Anything greater than 1.2 would be considered as alta, and anything less than 0.8 would be considered as bargia. So next case study, patient has a background of squamous cell lung cancer, presented with progressive back pain on the right, and has leg weakness, power 3 out of 5 bilaterally. Looking at the scans here, looking generally, you can see that you've got this abnormality sat here. And then looking in more detail, so based on the ones that you've previously seen that have been normal, you can see this mass here. And then looking at the spine, you can see you've lost the vertebra here and you've got this mass. Moving forwards again, you can see the destruction of the spinal, the vertebral bodies here, and the deformities and the gaps between the spinous processes. Again, here you can see this mass. So left apical lung tumour, invading the left posterior left rib, involving T1 to T4. Tumours continue to invade the left lateral recess. Also, there's involvement of the corresponding nerve roots within the neural foramina. So, thinking about compound fracture, non-healing wound, as you can see here, you're looking at non-healing tib, moving forwards, previous open fracture of the left ankle, non-healing wound, likely to need a free flap reconstruction. So they're querying the osteomyelitis because you obviously don't want to be putting a free flap over an area of infection because your free flap then won't take. So what they're looking for here is the fact they've got saucerization, loss of the fat plane medially. So here you can see that they've started to lose some of that fat plane. So they're trying to work out whether or not the flap itself would take. So you don't particularly want to be putting a flap over the top of that because you're suspecting that osteomyelitis. And that report just goes over that. Okay, so medial compartment osteoarthritis, had previous surgery for patella plica, small metal fragment in the medial femoral condyle, and to assess lateral tibiofemoral and patellofemoral joint prior to surgery. So looking at the images themselves, so you can see the images are of poor quality up into the femur because of that metal fragment. So this is metal fragment artifact that you're seeing here. So if we just move forwards, because that's not very good, useful to us. So looking at the knee itself, so we're looking at this laterally, you can see the bow tie sign. So when you're looking at the meniscus, you're looking for this nice bow tie sign here. But what you can see is that there is a tear into the anterior horn of the lateral meniscus, which is why you don't get that nice clean break here that you do on the posterior aspect at the front, because there's a tear into it. And that would be supported with the report just there. So I guess in terms of report analysis, you would never be asked to report on a MRI scan or an X-ray, but what you can do is you can spend that time looking over previous MRI scans and CT scans and just making sure you're able to see what the report says. Can you go back through them? And it's good practice to have a go at interpreting the results that the radiographer gives you. And if you're not sure about something, then have those open communication channels and go speak to your radiographer and see what they're seeing, or ask them to show you on the image what it is exactly that they're seeing that could be causing the issue.